What we've been talking about is different models of care. We've had some great experts come in to raise awareness, because if we don't raise the knowledge level of people, they tend to have a visceral reaction to concepts. And I always say this, the day my son was born was the happiest day of my life. The next day, when I found out about his diagnosis, it was the most frightening day. And all of us go back to that position where we're scared, we're frightened, we don't know what the future is, and we're all in that together as parents and family members. And we need to make sure that we're helping, doing our part to evolve the system.
Welcome back to Finding Common Ground with Heather and Steve. Today, our guest is Nick Cappelletti. He's coming to us as the CEO for our Life Plan and ACA that serves about 47,000 families in the state of New York. And Steve helped us make this connection. Why don't you let our audience know how you guys met?
Sure. My son is a autistic young man. He's 35. When he went from Medicaid Service Coordination to Care Coordination, my son transferred from Family Advocacy Center to Life Plan. And it's been, we weren't sure, when you're a parent, you're not sure change. It was a good change, and it's been a great change going over. I think I've known Nick now 7-8 years. I've served on several committees at Life Plan, the member engagement committee, and several other things. And I really enjoy doing that. It puts a family member at the seat at the table. So I'm glad that Life Plan has allowed me to do that. And Nick, maybe you can explain a little bit about yourself.
Well, thanks, Steve. And Heather, thank you for having me on. Again, my name is Nick Cappelletti, and I, first of foremost, am a parent of a child with a developmental disability like Steve. I also have a 35-year-old son and who's on the spectrum and has a unique genetic syndrome. Been involved in the field for over 20 years. And when the CCOs were formed, I was able to, given the great opportunity to lead Life Plan in 2018, and then later through a partnership between Life Plan and ACA, was able to lead also ACA. So the two organizations, as you said, Heather, Life Plan serves about 20,000 people in throughout upstate New York down into the Hudson Valley. And then ACA serves about 27,000 people in the lower Hudson Valley, New York City, and Long Island.
That's a lot of people that you touch with your work. That's amazing. And knowing that you're personally connected to the disability community, that means a lot too. I think a lot of times we have people talking for us that don't walk the walk with us. And I think that makes a big difference when it comes to how things trickle down to the rest of your community. We already brought up kind of the elephant in the room. A lot of people, when we moved from Medicaid Service Coordination to care management, there's some strong feelings. And when we were prepping for the show, it's like those rose-colored glasses when you look back at things. And I was thinking about it last night. Sometimes when you're in that middle of that trauma, like a new diagnosis or uncovering something about your loved one that you didn't know, and you're in turmoil and you're trying to understand it, the people who surround you in that moment become almost like family themselves. They're the ones pulling you up, putting you back on your feet, and it's very natural to have a really positive memory associated with people who helped you at the beginning of your journey. So for a lot of us, it was a Medicaid Service Coordinator. They were the ones who started us off. And as I think about it, I had a great one, but there were some conflicts of interest, and there were some things that kind of took away from what they could do. Maybe you could just help our audience appreciate some of the differences between the two and why it's a good thing, like the evolution of this, that it's still evolving all these years later.
It is still evolving. Yeah, no, great question. And, so with my son, he's had a Medicaid Service Coordinator since he was 8 years old. And my first career, if you will, or experience with the IDD field, other than being a parent, was working with a group, a family support organization out of Syracuse, and we actually started an agency, and I was their very first Medicaid Service Coordinator. So I did that role for almost a decade. And the Medicaid Service Coordination, through that program, we connected thousands and thousands of people to IDD services, helped them qualify for Medicaid and other services, help them, really lead their more inclusive, healthy life. So when the change from Medicaid Service Coordination to Care Coordination Organization was first proposed, at first I was somewhat concerned and said, no, that this, I was somewhat felt that, you can't make this program any better. But then as I learned about it, I saw that there were some distinct differences and some real value to be had. If we look back, the Medicaid Service Coordinator, and again, different service coordinators did things differently. Some agencies, there were over 350 agencies that provided Medicaid Service Coordination in New York State. And it was probably, you had a vast diversity in approaches, skills, training, role. It was fairly loosely defined by the agency. So when we went to Care Coordination, the first thing was that these are going to be MSC plus. And what that means is that it would embody the job of the MSC, which was coordinating IDD services, helping people get enrolled in the waiver, helping them connect with Medicaid, certainly help them create a plan and get connected to IDD services. But then it was more. And the more was, it's a health home. And New York State had almost a decade prior, 8 years prior, started rolling out the health homes. And health homes it's kind of a misnomer. It's not really a home, but it's an organization that focuses on the health outcomes of a population. And the CCOs are a hybrid. They do the Medicaid Service Coordination, but they also focus on health outcomes. And as a parent, I know that, my experience is that when my son's health is off, when I can't find the right provider, he's not really living life to the fullest. He can't take advantage of any of the IDD services. So if we have a child with autism who is having significant behavioral challenges and the family can't find them the right psychiatrist, the right behavioralist, or even just basic health care, then that individual is really not going to benefit fully from the IDD services. In addition, when we have individuals who are in health crisis, they tend to need a lot of crisis services. And those can be very expensive. They're not optimal. And the whole point of the design of CCOs was to develop a role in care management, different from Medicaid Service Coordinator, where people would actually be focused on health outcomes and IDD services. It would be a whole person approach, looking at all of their needs. It would help connect them to the right resources. And part of the opportunity with care coordination organizations is, instead of having 350, there would be fewer of them, a couple per region to give people choice, but they would have enough size and scale that they could invest in the care managers, they could train them, because again, it's a different job. It has a lot of different expectations and different skill sets needed. The CCOs could invest in clinical supports to help the care managers when we have people going in the hospital, discharging. We can invest in population health so that we can actually start studying trends, issues that are affecting people, maybe identify potential opportunities for intervention. We can do more coordinated discharge planning for people who are cycling in and out of more complex settings. We could support people who are transitioning better. So when the model was first floated, again, I didn't want to give up my MSc. I ran an agency that provided MSc, but then it was like, wait a minute, this makes too much sense. Knowing that it was going to be quite a transition. And it was a huge transition because whenever you take thousands of people, redefine the job, move them from one agency to another agency, it's a huge disruptor.
And then there was a global pandemic, just a couple
exactly.
years into it. So you didn't really get in your groove. And then when we talk about turnover and things, that's happening everywhere since the pandemic. So the timing probably didn't work in everyone's favor, but it all happened. So
the timing was a challenge because we stood the CCOs up in July of 2018. That was the go live. And the good news is, I mean, even though it was a significant change, everybody had a care manager on July 1st, 2018. And the CCOs all had the lights on, and we were able to transition. And some service coordinators, depending on the region, the agency, the CCO, were able to phase out over a period of time. Some started immediately. But over that year, from July 2018, by the time the following year rolled around, everybody was enrolled, and every care manager now worked for a CCO. And then we had the global pandemic. So you're right, there was a lot of change, and the global pandemic really impacted all workforces, but it did acutely impact care coordination because we depend on just not because of any other reason. It's just that the demographic for care managers tends to be people who give care. And a lot of them were then put in a difficult position of we were able to work remotely, but still the demands of having children are no longer in school, they're staying at home, being caregivers. Some of our care managers had to leave. And so we did face workforce challenges during that period. I'm glad to say, though, that now things have really returned to normal, and we've really been able to rebuild the workforce, and as most organizations have, and things have now leveled off.
That's wonderful, too, because I think I mentioned to you before, we had a wonderful MSc, and then we transferred over, and we had a really great care manager up until the pandemic, and then for the reasons you're discussing, she couldn't do it anymore. It was about 18 months where we had a supervisor who was kind of supervising all the tier 4. And if you're not familiar with the different tiers, tier 4 is supposed to be like the more complicated individuals, the ones that need the monthly support check-in. Me as a professional in the field, I was okay. I could kind of navigate it, but there was a lot going on right now. It would have been nice to have somebody, but we were assigned a wonderful care manager after those 18 months, and she has been with us consistently. I can text her, call her, email her, and that makes me feel good because part of it is when you redefine something, it does take an adjustment period. The people who are just upset that it's different are going to fight it, right? They're going to make it harder. But then there's also that thing that once people actually appreciate this new understanding of it, it's going to attract other people and more people that want to do that kind of work. So I think that it's chiseled out a nice little section of people right now that are like, this is very meaningful work. We're doing really important things, and it's an actual career. I know a lot of times people say they must not pay them very much. No, I know they do, right? I mean, this is like a real profession. You have to know a lot of things to be a care manager. That's the other thing that I want our audience to think of. Next time you're really like frustrated because you're in the middle of something, think, I can't expect my care manager to know everything. Her job or his job is to find the answer for me or direct me towards the person who can help me. I can't expect to text them and get an immediate response with the exact solution that I need in that moment because we're not human computers, we're people.
Right.
So.
Yeah. And I appreciate you saying that because I just, prior to this, had a orientation session with about 40 new care managers for both organizations. And part of it is I, kind of talk about our mission, and I ask them to all introduce themselves and say where they came from and, what brought them to either ACA or Life Plan. And you hear such diverse experiences. People who have worked in special education, in IDD services, in child welfare, in mental health. And what gives me great satisfaction in really, I think, is the value of the CCOs is that we do have a very experienced workforce. And they come from all different settings. So if someone doesn't know the answer, chances are somebody else does. And I shared that with the care managers. I said, you may not know every answer. Your job is to go find the answer, but chances are, if we can't get it, we have connections with the state, we have connections with providers, we have connections with other support community-based organizations. We'll get the answer. Don't let go of the question until we get it solved. And I think that, some of the backgrounds, the care manager job actually required a lot more than the MSC role. It required people, first and foremost, to be very efficient and savvy in technology, because all of our documentation, all of our assessments now, all of our life plans, they're all electronic. Secondly, it required them not only to know the IDD services, but also to understand what was required as a health home care coordinator. And some of them didn't have the knowledge or the familiarity of, being able to input diagnosis codes and take a physical and see that physical and pull things out that might be pertinent to an individual or critical to an individual. And also New York State really added a lot more complexity into it. Not, in some of it, I think is the value of it is yet to even be fully appreciated, because we're tracking data on the population. There's going to be a time where we're going to be able to analyze that data. And we're already starting to do this at the CCO level, where we can see trends. And, we're putting population health initiatives in place to hopefully reduce the number of times people have to go to the emergency room unnecessarily, or potentially get preventative care to prevent either more complicated illness or potentially hospitalization. So we're really trying to gather information and learn from it so that we can not only hopefully help people improve their health, but then better participate in the IDD services that can help them live the best life in the community.
And you just brought up the other elephant in the room, Medicaid, right? Because many of our loved ones utilize Medicaid to pay for things. And with the new administration and all the talks about what will happen to Medicaid and what will funding look like, you said something yesterday that really stuck with me, that crisis is an opportunity. It pushes you to look at things in a new way, to invent a different way, maybe a more efficient way. And so that while we don't want to sit here and really dive into all the possible cuts because we don't know yet, I think it's important for our audience to appreciate that piece of it, that, we might not know what the budget will look like on the federal level, and we're still figuring out what it's going to look like on the state level. But it's more about how we respond to it, what we do with it once we have that information. So I don't know if you have any insider ideas for our audience, because it's pretty gloomy on social media and at the coffee shop, right? There's a lot of people complaining right now and predicting, and all of a sudden everybody's an analyst. They know exactly how this will play out. So.
Right. Yeah, you can't pick up social media or the TV and not hear the talking heads talking about the changes and the prognostication of the gloom and the doom. Here is what I think. And again, I look at this personally as a parent. A couple things. One is right now, New York State's in the process of finalizing its budget for the next fiscal year. And things look fairly positive for that budget. The governor proposed a COLA, a cost of living adjustment for IDD services. and the Senate and the Assembly have actually proposed even a bigger number, which is good. We would like to see the CCOs included in that. For some reason, we were kind of left out, and it's important for us to keep care managers' salaries competitive. But I think at least for the New York State next fiscal year, we're going to end up with a COLA. Hopefully, it's not going to be less than what the governor's proposed, because both chambers have said, more than that, which is good. And I think that that's as far as we can look out for New York State. Now, the federal government, there has been some talk about major changes, Medicaid, cuts to potentially entitlement programs and programs. We don't know what that's going to look like. We do know that New York State is very dependent on the federal share, right? So a little over 50% of our Medicaid is paid for by the federal government. Now, the good news is, while we're the second largest user of Medicaid, we're also the second largest contributor to the federal budget. So New York State does, pay for its fair share. And depending on what happens at the federal level, New York State, I think, is financially stable. Hopefully, we've got some rainy day funds. By the time those changes get implemented, hopefully New York State's going to be in a position to react to it. I don't want people to be nervous. I do want people to be knowledgeable. I suggest people get engaged, that they subscribe to reliable news sources, that they get connected with organizations like, Disability New York or Anchor, that they have one-click programs which will connect you to your elected leader. If something comes up that you either have a question with about, or if you want to use your voice, right, and tell them that this isn't acceptable to me. It's going to be very important for us to, reach out to our Republican federal legislators, because those are, they are in majority right now. And I think we have to wait and see. I also, it's not just the people who receive the services that need to be active, but also the members of their family and their support team and their staff, that all need to be looking at this to make sure that we all advocate for the population and any changes that may negatively impact the population. And certainly the CCOs have a program. We've been pushing it out across all 7 CCOs to keep people informed, let them know what's going on both in Albany, and we'll do so at the federal level. I know Life Plan and ACA, we just sent out, Senator Schumer was doing a roundtable, and we let people know about that, because it's important for them to hear directly from our elected officials.
Absolutely. That's where Steve comes in, because he is frequently interacting with people at all different levels, across both sides. And I think that our audience, sometimes the feedback we get is, it sounds really great that you guys do that, but it makes me feel nervous. Like I can't pick up the phone and call them. So Steve, just break it down for people, because it's not that hard, right? To get somebody's attention, to send an email, make a phone call.
Yeah, I think I mentioned this before to Heather. Somebody asked me once in a training that, how do you get into these people's offices? And you know what I tell them? I do what they don't. And a lot of that is I plant seeds, and it's what I call it. And I start things on a local level. I build a relationship up, and locally on both sides. I don't ever look at it like the letter after their name in politics means anything to me, because it doesn't. In disability, my son's disabled. I don't care if they're a Democrat or Republican. I just want to know who's going to help him. And I use that approach all the way up through. And when they do that, they realize that you're fair. You're coming in you're balanced, and you're not going to have a predisposed take on anything. And they hear me out. Nick, I didn't get a chance to say too much about it yesterday, but the approach that she's talking about literally allowed me to reach out to Willow Bear and pitch a proposal to her to do a family listening tour. She's coming to my home.
Oh,
And
wonderful.
we're going to be the host for the first one in the state at my house. And they're going to do different areas of the state. And she's literally going to go there and listen to families. She's going to listen to the self advocates right in their homes. And we're looking at the parameters now of, a few families because we don't want to overburden it. But we want to keep the politicians out and we want to keep the media out because we want it real and we want it genuine. And it's that approach. It's just like the politicians is what I do with the elected officials and the commissioners in these state programs in order to get in their office. And it works for me, and it always has. And I literally was called to ask to speak in Washington D.C. I had no intention of going there, and now next week I'm going to spend a week in Washington D.C. with the same politicians. So I'm hoping that I can relay some of these things that we're talking about. I wanted to go back to one point when you're talking about the need for the care managers and all of that. It is so important in my son's life and so important with the kids that I work with that have OPWDD. To have care managers to understand that a lot of them are autistic. They don't like change. They don't want 10 care managers. So it's important that you guys are allowed to get a COLA or whatever they're calling it now to be included in that for a reason, because you guys need to be able to take care of your care managers so they stay. And I'm in other agencies and they have turnovers weekly. And, and these kids are the ones that feel that part of it. And it's important that they, my son doesn't want change. He doesn't want any change. He doesn't want to talk to 10 different people. Right. And so if he can get one care manager, we've been very fortunate with Life Plan to have you guys because we've only had a couple and they've been excellent and we've never, ever had an issue. And like Heather said, every time we make a phone call with if something comes up, they're on it. And so I wanted to make sure I mentioned that piece to you too.
I appreciate that, Steve. Yeah, we try very hard to minimize any disruption, and we do invest heavily in the care managers and training, in supervision, giving them the skills. Every care manager at ACA and Life Plan has to go through a very exhaustive certification process. We make sure that they understand the material, that they've got the support. We observe them. We don't want to lose them. So if we don't keep salaries up, they've got to pay for their bills. They've got to support their families. So we need to be fair to them as we are to any other service. And I agree with you. I mean, my son doesn't like change, and having continuity is very important, not just from a relationship standpoint, but also from a knowledge standpoint, right? Because when we get somebody new, then we're back to square one in teaching them about.
You have to learn them all over again, right? Yeah, exactly.
It's complicated. It's a complicated system. It's a complicated population. And you put those two things together and you don't want to lose good people.
Yeah. And part of what you were saying, too, comes to equitable funding. Sometimes you hear about the budget and you're like, okay, why didn't the CCOs get that? Or why did Certify get this big chunk of money and then Self-Direction, who serves more people, maybe not more people, but, why isn't it more equitable? Why aren't we distributing it in a different way? And I would love to hear your take on that. Like, how could we even the playing field? So it wouldn't matter if you were in certified or self-directed. It wouldn't matter what part of the state you lived in. That would kind of level the playing field for people, and they would have the resources they need depending on what they need at that moment, because we change over time.
Right. Yeah, that's a great point. Our system is over 50 years old, right? So it really was born when they closed Willowbrook and the institutions and started creating at first, more of the certified services. And then later we added some of the community-based services and then the self-direction program. And right now we are in almost close to having as many people that do self-direction that are in certified. And what I mean by that is people who live in group homes or that setting. There are inequities in how we fund. They're well known. We have some arbitrary numbers and we make some distinctions that may not necessarily be valid or accurate. And we do need to move towards, and this is part of the evolution of the IDD system, we need to move towards a model where people are receiving supports based on a objective assessment of their need, right? So I know some people, we've got multiple assessments right now that the care managers have to do, and then we have the CAS assessment. And we need to really move towards a uniform assessment that we feel confident in, that's transparent, but that does an assessment and assigns a level of resource based on that need. And it should be available to people to then use where they choose, right? So it really should be where money follows the person, and that we, if you look at Olmstead, you look at ADA, you look at some of the legislation that we've really built this system on over the years, that we should not be, we should be giving people choice to lead lives and live in the least restrictive environment. And if they choose to live in their sister's home or their best friend's home, there should be a level of support and resources that are there, or their family's home, that is equal to what they would get if they were to choose a more certified setting, right? We've made tremendous progress, with the nursing home diversion waivers and allowing people to live in the community as opposed to nursing homes. But right now, we don't have that same level of equity for people who live in the community. And I'm not suggesting at all that we take away resources from one. We need to add resources to the other. And I feel very confident, Steve, you mentioned Commissioner Bear. She's acknowledged this issue. She wants to invest more in community services. I think we have to ensure that we're getting reasonable COLAs and keeping those services competitive, because at the end of the day, those services in many ways cost the taxpayers less. People seem to want them. I mean, most of the people that are on our waiting list want self-direction. So there's a lot of people who want to continue to live in the communities. But then we also have to have a full menu of services for people, because you might start with self-direction, but then you may need more support. So we need to make sure that as people's needs change and those assessments indicate those changes, that the amount of resources that goes into their services grows with their changing needs. Because right now we have 130,000 people in the IDD system. People are growing older, they're living longer, but they're also living longer with more chronic issues. And we have a huge surge in kids who, primarily children, who are on the autism spectrum. So we need to have a system that actually plans for the aging of its existing population, the growth of the population, and knowing that perhaps our current portfolio of services is not necessarily matched or funded the way it should be to meet that population dynamic.
This is the perfect point to bring up the Whole Person Supports Coalition. I don't know. I don't think we've mentioned it in any of the other shows. So let's introduce it to the audience so they have an idea, because reimagining how we do things. The Jennifer Lunsford, she's a local assembly member for me. She used this expression or this story to explain it, saying it's like an old Victorian home, and the front door used to open into this beautiful foyer, but then you needed to put it on, an addition because other people moved in, and now there's staircases that go to a wall and a window that opens up, to the garage, and nothing makes sense anymore. Instead of adding on to a system, sometimes it's better to start over or to take the pieces out that worked and build something new. And that, I feel like in a way, that's what the Whole Person Support Coalition is about. But I would love to hear your take on it.
Yeah, no, that's a great analogy. So, if we take a look at our current system, in New York State, I mentioned that we have about 130,000 people in the system. And it's not 130,000 people in New York State with IDD. We know there are many more. In fact, Department of Health has done some studies that show another 200,000 people on Medicaid that don't have OPWDD services. So we have 130,000 people in the OPWDD system. If you add what we're spending, the total amount of Medicaid, federal, state share, and state resources that are spent on the population, and then you add the Medicaid and Medicare spend because of the health care, we're probably spending over $15 billion on that 130,000 people. The good news is New York State is actually a very generous state. The bad news is that we have somewhat of an antiquated system, and it's not evolved. It's still very much, kind of put together with some, programs that we started 40, 50 years ago that we haven't really evolved. And so it does need to be, in some ways, for lack of a better term, reimagined. There was some movement, certainly the CCOs and the creation of the CCOs to take a look at the whole person, look at their healthcare needs, try to keep people out of crisis was the start of reimagining the system. But now we have to extend that to the rest of the system. And we have to really look at, and this was part of the Whole Person Coalition, is let's look at the whole person. What are their needs? How do we improve access to healthcare? I know for my son, it's challenging finding specialists for him. It's challenging finding doctors who want to serve him. Medicaid, as we know, doesn't pay the best. And now we're talking about the IDD population that has chronic conditions, both behavioral health as well as medical issues. They're aging. They don't necessarily all understand their own bodies, and some of them can't communicate very well. So for a doctor, it's a complicated population. It usually requires more skills, more time. It takes longer to make referrals. There are less providers who want to take people with IDD. Some people need accessible offices, accessible testing equipment. A lot of doctors don't have that. So we're really not meeting the needs of the population. That's one issue on a healthcare standpoint, and we know that it's been published. Health outcomes for a person with an intellectual developmental disability, a person with IDD will live, setting aside their disability, will live almost a decade less than their typical peer because they're not getting access to the right healthcare. And if you're a person of color, it's even less. So we really need to look at the healthcare component, and then we have to look at the long-term supports and say, are we really spending our money wisely? Is there a better way to allocate resources, assess need, allocate resources, and support people, giving them more options, more choices? And I think that, there's some basic inefficiencies in our current system that we might be able to address and free up resources so that we can do some of those things. Doesn't necessarily always require more money. Sometimes it's just we've got an inefficient design. We make some things complicated. And if we can learn from that, and we've done a lot of work, the Whole Person Coalition, what's so great about that is it's been facilitated by Courtney Burke. Courtney was IDD commissioner. She was deputy, or I think she was Secretary of Health and Human Services. She's got a phenomenal view of the system, and she's been watching it. She's dedicated to the population. She's been hosting these conversations. You can go to the Whole Person Coalition website about different models of care that could be explored for this population. It's really a multi-stakeholder, so it's got individuals, self-advocates, family members, providers, interested participants who want to see us reimagine the system, not tear it down, not cut anybody out of services or force them to move, but can we do this in a way that we are at least moving towards a more sustainable, equitable, and better outcome system?
And that's such a good thing for our audience to hear, because sometimes we think that these kind of decisions and ideas are just in a boardroom and there's no parents, no self-advocates present. And the coalition has made such a big deal and made such an effort to bring everybody to the table. I appreciate the conversations, and they're very detailed. They take notes on everything. They compile the notes. They compare the points that are the same. The next time you meet, we go over the things that stood out, the things that didn't align the same way. Okay, if we took this model and this model, what are the best parts? Like, how can those be married together? And it really gets you thinking in a more creative mindset, because a lot of times we are in our angry mindset. We're not getting what we need. Our kids are suffering. And what will happen when we're not here? And then you get in that angry, upset mindset and your brain shuts down. It's hard to problem solve when you're angry. And there's no anger there. I mean, people might bring up a frustrating moment and say, like, I wish this wouldn't happen anymore. And then we break it down. How could we stop that from happening to all these families? So it gives me hope. I enjoy being part of those meetings and those conversations. There are so many meetings a parent could sign up for, or a self-advocate, that will drone on and talk about the same things every time you meet, but nothing's happening. This feels like we're going to have momentum. There's the right people in the room to get these ideas in front of the right people, right? Like, that's what you need, because you could come up with an amazing idea in your backyard with some other families that are over for a barbecue, but how do you launch that idea? How do you get it in front of people? So I think that it really does bring all that together.
It's a great, it's a broad coalition. We've had participation from individuals and families who take advantage of certified group home services. We have individuals and families who take advantage of self-direction, individuals and families who are not getting services. We have a variety of providers, and, it really does, the more people we can bring in, and we've got some values that are listed, right? And I think the values tie us all together. We want a better system. We want it to be efficient. We want choice. We want, we don't want to leave anybody left behind. And we seem to be really gaining a greater understanding of there are different models out there that if we consider them, it could actually benefit this population. One of the things that was somewhat of a polarizing concept was managed care. And it was really because a lot of people have the old model of managed care in their minds that I'm going to have an insurance company that's going to be saying no all the time. And we've all been frustrated when our insurance company says no to a test or a prescription. But that's only that is a very limited understanding of what is being suggested when you look at like a model of care that actually does take and builds the network of providers, actually does have specialized skill sets to serve the population, and has an incentive to keep people in their homes and in the community. So what we've been talking about is different models of care. We've had some great experts come in, Marco Damiani from AHRC, who's talked about, serving people who have complex behavioral health medical needs. We've had Arch Care talk about the PACE model and how it could apply. We've had Brett Friedman, who used to be the New York State Medicaid director and is a national health expert and an attorney, talking about different models. So we're really trying to bring experts in to raise awareness, because if we don't raise the knowledge level of people, they tend to have a visceral reaction to concepts. And, and I always say this, the day my son was born was the happiest day of my life. The next day, when I found out about his diagnosis, it was the most frightening day. And all of us go back to that position where we're scared, we're frightened, we don't know what the future is, want to know what happens when we die. And we have to kind of realize that we're all in that together as parents and family members. And we need to make sure that we're doing our part to evolve the system. Mm-hmm. Or else we won't be there for our kids.
Right. Because how will the system really know us if we don't stay involved? If we detach and we put our head in the sand, or we're crying in bed with the covers over our head, nobody knows what's happening at our house. Steve and I are part of the Coalition for Self-Direction also, and they had OMIG come in. And they're always called the big bad wolf, don't get audited, oh, be careful, that community class that you're going to get audited. And it was kind of nice to see them come in and talk about what their role actually was. Sometimes just it dispels the misconceptions. It breaks them apart.
Absolutely.
And then people are like, oh. And they said, you know what? We don't even have an auditing process for community classes. And everybody in the room, there were a lot of FIs were like, what? Like, we've been so scared of getting audited that we've probably been a little more cautious than we needed to because we didn't want to get in trouble. And they said,
Right.
well, what if we aligned with you? We learned what those subtle nuances were, the hidden parts of your life that, an outsider might not know. What if you were part of the discussion and you helped us make the auditing process, and you could see the tone and the temperature completely change in the room, because now it wasn't these big, bad, scary people who are going to get you in trouble. They're saying, we want to understand, because when we come in and audit, it's not to get someone in trouble. It's to make sure you're compliant with the guideline. Are you following the guidance? Are you bending the rule? Is it, and why? Like, if they see a trend and they say, we keep noticing this pattern. And when they described it that way, I was like, oh, they aren't the big bad wolf.
Right.
It can be scary, and I'm sure nobody wants to get audited, guys. But at the same time, if we don't have checks and balances, it's not good either.
Yep.
Right?
No, it's a great point. And, I think, you look behind OMIG, you look behind OPWDD. They're all good people. They all want to serve all of us. OMIG plays a role. It reduces fraud. It takes away, some of the bad people, right? And we're dealing with, billions, and we need to make sure that we're using it the right way. And we are accountable to the federal government and the state government and the taxpayers. One of the things, though, that I think causes a lot of challenges is that we, in New York, we do have a highly regulated environment. And in some cases, we've regulated beyond reason. We don't necessarily need to have all this regulation. We compare ourselves to other states, and part of it's just our heritage. I'm not blaming any one person. It's just kind of builds upon years of so to the extent that we can reimagine the system and we can look at what's reasonable regulation, how do we make programs as clear as possible so that there is no fear? You know what the rules are and you follow the rules. The FIs understand the rules, right? The families, the members, the individuals follow the rules, and OPWDD understands the rules. So can we come up with common sense-based regulation? And it's not just on the funding. It's also on all the other pieces, because we do have other regulations that we've discussed that, does this really make sense? Are we limiting people's choice? Are we being rational about risk? Because, you could, if you want to eliminate all risk, then that might mean you have somebody sitting in a jail cell.
Right. They're in a padded room, right? Exactly.
Right. And there's risk just in putting somebody there. I mean, we don't necessarily always calculate the risk, right? The risk is isolation and no quality of life. So what are all the risks? I remember this debate with self-direction where it was, well, do you allow people to go to a water park in self-direction? Well, if the person wants to go to a water park, they should be able to go to a water park. Is there risk there? Well, yeah, but there's risk for me and you every time we take our car, every time we go to a water park.
Right.
What is reasonable? Do we allow people to make their own decisions? Because sometimes there's this institutional or paternalistic view of everything where we have to regulate, we have to mitigate, we have to make sure there's no risk. Well, that's not reasonable, because with quality of life comes a level of informed risk.
Mm-hmm. And people are allowed to make mistakes or try something new and then say, I guess that didn't work, or that's not the right place for me to hang out, or this neighborhood didn't work out. And I think that for some reason, when we think of people with IDD, and this is a parent thing, a provider thing, we're like, we need to find a place for them to live when they're done with high school, that school bus stop coming. And then we want it to be this place they can stay forever. And I say, my goodness, I have not moved a lot, but I've moved a bunch. You know, like it's not natural to go to one place and stay there your entire life and never have a different apartment or a different neighborhood or move to a different town. Most people do that. It's normal. And instead of trying to like lock people in place, got you taken care of, check you off the list. Okay, who's next? Things can change and people change and what they want changes. We'll end on a story, a personal story for myself, just because I have been spending a lot of time with this gentleman. He is a young man, and the audience has heard me talk about him before. His name is Flip, and he lived in a nursing home. And it was a 500-bed nursing home. And he hated it, if I'm being honest. It's not because the place was necessarily a bad place. It's just he wanted to be out in the community and to have a job and to have neighbors. And they would always say, because he had cerebral palsy and he's non-speaking and he is a quadriplegic, it's not safe. How will we know? What if a staff calls off? And I said, well, that can happen here. Well, then there's still people here. There's still eyes on him. And I'm like, but his cognitive ability and his ability to communicate with his communication device are great. So we just have to make sure he has access to what he needs so we know if he's in trouble. He's allowed to be by himself. I mean, they really thought this he was in his mid-30s at the time, that he needed someone like looking at him all day. I said, you guys, I worked at the nursing home. He was out and about. I mean, he'd be flying down the sidewalk. He'd be over at Lowe's. He's at Home Depot today. Like, everybody knows Flip. So we have to reimagine how we look at people, too, and just say it's okay. If he gets himself in a mess and his chair runs out of charge and he has to call somebody because that didn't work out, he learned something. But if I tell him, no, you can't go to Home Depot, it's too far from your house, I'm just being a parent. And I'm not his parent. I'm his friend. And I don't want that for him, and I don't want that for my daughter. When I started raising the bar and having expectations, things change. Because guess what? We don't have enough staff, guys. We don't have enough funding, right? So all these models in our head where our kids are completely wrapped in bubble wrap and nothing will ever happen to them, that's not realistic and it's not fair. So thank you so much for this conversation, because I think that's the perfect way to end it, just to talk about it's okay to take risks and to try new things. And that I hope all of this changing and shifting at the federal and state level and at the local levels, the apple cart tipped over. Let's, write it up and see how we can get the apples back in and see what fits and what we need to do different. Because if we're being honest, what we were doing wasn't working. We were losing ground the last 10 to 15 years. So it's time for something new, and we're ready, right?
We have to be optimistic, we have to be hopeful, and we have to have people involved.
Absolutely. So thank you so much, Nick. Is there anything you want to add on, Steve, before we head out?
No, just thank you for being there. I think it's important that we're all there. I like to represent the families out there all the time, but I also know that we need you guys. And we, my big beef, you brought it, my biggest beef out of all of this stuff is the regulations part of all of this. I can go into so many deals. One of the things I'm going to Washington, D.C., I want them to hear what's boondoggling some of these kids that come through my home and where it affects everything. But it's a lot of the kids that come through my home are probably going to wind up in OPWDD someday. They're probably going to be in Life Plan because they've been through trauma, the autistic, and all other kinds of things going on. And I think it's important that we make sure that you're sustainable. You guys are all sustainable as a CCO. So Heather and I appreciate you being there and coming on and explaining to our audience what we're doing.
Well, thank you so much for the opportunity, and I appreciate you giving me this forum. So,
absolutely. So thank you.
Thank you.
And until next time.
Continue the conversation by joining our Facebook group. If you're a fan of the show, please join our supporters club. Subscribe on YouTube, rate and review on your favorite listening app, But most of all, share it with your friends. Just one more click or comment can make a huge difference and help us to continue finding common ground.